Okay, so welcome everyone to this evening's Doctoral Inaugural Lectures, or whatever time it is, wherever you're from. Thanks so much for joining us, and to everyone that's on the recording, hello. Thanks for watching the catch-up. Just a few housekeeping things to go through first. I hope you can all see my screen okay. So first thing is the session will be recorded. Your mic and your video will be turned off as you arrive, and they will remain off while the speaker is speaking. However, once we go into the question and answer session, if you do want to speak and use your mic, that can be done, but I just need to do a couple of settings, so just give it a couple of seconds. If you ever have an issue during the session, please use the chat function. I'll be monitoring it as to not interrupt the speaker. And feel free to ask questions in the chat function. And like I said, we can unmute your mic when the time is right. Today we are using Microsoft Teams. So you can adjust if you see a presentation as your full screen or the speaker, and you can switch that by simply clicking on which one you want to look at. You can also pin a video by clicking on the three dots on a person's screen, and if you click them, it will give you the option to pin. And you can also reframe a video in the same way, because Teams can sometimes crop it a little bit, and you can just select fit to frame, and that will sort out the entire video. But I'll pop these prompts in the chat as well if you want to have a play around with that. So that's everything from me. I'm now going to pass on to Professor Dave Lambert, who is the Dean of the Doctoral College. Thank you.
Thanks, Kelly, and I'd like to extend my own welcome to you to this evening's Doctoral Inaugural Lecture. These are very competitive and highly prestigious. There was a big field, I think, in CLS, so to be selected for these is actually quite an achievement. So we're really looking forward to hearing what our Doctoral Inaugural Lecturer has to say to us today. So this is also the Ian Lauder Prize lecture as well. So Professor Ian Lauder was a previous dean of our medical school, and he sponsors the Lauder Prize. I think there's a Lauder Medal as well, which sadly I'm looking at a screen and there's no opportunity to present anything, but I'm sure that will come your way in the fullness of time. So typically we have two Doctoral Inaugural Lectures in one of these sessions, and the second speaker, Hannah Smith, has pulled out for reasons beyond our control. So that puts us in quite a nice situation that we're able to give Helena a little bit more time to speak, and it will give us a little bit more time towards the end for some meaningful Q&A. So do start thinking of some questions as she's speaking, and we can open this up at the end and have a little bit of a discussion. Again, it's a bit sad that we can't be doing this in person, but we are where we are. It's going to be recorded, so it'll be seen by all of those who couldn't make it to the session. So our speaker this evening is Dr. Helena White. So I suppose I should say Doctor with an MD and an MB CHB. So make the most of it for now until you can replace that with Professor. So Helena is a consultant in infectious diseases at the LRI. I'm not going to say too much about her journey or her story. She might want to tell you that herself as she goes through some of her talk. So she's going to be talking about HIV-related TB in the UK, and she's going to give us some stuff on epidemiology, practice, and control. So, ladies and gentlemen, I give you our Doctoral Inaugural Lecturer for this evening, Helena White. So, Helena, screen's all yours, and I'm going to go mute and disappear. Over to you.
Thank you very much. Okay, I'm just going to share my screen now. Which hopefully everyone can see my first slide.
Yeah, I can see that.
Lovely, thank you very much. So thank you for inviting me to speak. You know, it's an enormous pleasure to share my MD work with you, and also a pleasure to accept the Lauder Prize. So thank you very much indeed for that. As we said, I work at the LRI, and I'm actually a clinician. In fact, I don't really have a research background, but got cajoled into doing an MD a few years ago when I was still a registrar by some colleagues who thought this might be a really interesting topic to look at. And I have to say, once I started, it was something that I really felt I was able to get my teeth into. So it's been a real pleasure to have the opportunity to do this, and I hope it will lead on to some future research work. In terms of my disclosures, so I should mention that very early on in the MD process, I was awarded a Registrar Research Award, which was awarded jointly by the British HIV Association, but also with Gilead, who are a drug company. So they make medications for individuals with HIV. They haven't had any involvement in my research at all. They were just kind enough to give me a small amount of money, which covered my fees for, I think, the first year of my course. My supervisor, Dr. Parikh, is supported by the NIHR. So I'm aware that some people on the call may not have as great a knowledge of clinical tuberculosis as others, or they may have purely been involved in it in a research setting. I think really to say that TB is thought to be quite a spectrum, really, ranging from the clinically obvious or radiologically evident TB, which are the cases that we might see on the ward or people presenting as an emergency through the hospital system. So, people that are sick, they've got a fever, they've got a cough, they've got abnormal imaging, and where you can readily grow the TB bacilli and are confident to say they've got active TB and need treatment. But there are then beneath that, almost probably pyramidal, an enormous number of people who have been exposed to TB. They breathed in the tuberculosis, but that is lying in some form of dormant form, probably within the macrophages in the lungs. And those individuals may be considered to have what we call latent TB. And the importance of that is that over time, there may be a number of reasons why they may be pushed from a latent TB state to one of active disease. And clearly that has with it morbidity and mortality implications for themselves, but also then a public health implication for the remainder of the population, who then may be exposed to active disease. So the idea is that if you can, you could try and identify people with latent TB and offer them chemoprophylaxis, so essentially sort of low dose TB drugs, in order to try and prevent them moving to active TB. And in the past, we've had a variety of ways of being able to identify people with latent TB. So they might range from the simple X-ray procedure, which might show a calcified granuloma and give an indication that somebody's had primary TB before. It might be an old-fashioned Mantoux or Heath test, which are the skin tests that people might remember, but they do have problems in that there's a lot of cross-reactivity with those tests with environmental mycobacteria, so they're not specific for TB. And the newer tests that are on the market and have been around now for probably 12 or 13 years are what we call the interferon gamma release assays, or IGRA tests. And essentially what they do is to identify interferon gamma, which are released from T cells of an individual who's already been primed. They've already been exposed to TB. And when you re-challenge their bloods with Mycobacterium TB antigens, their T cells then release interferon gamma, which can be measured. And these are thought to be really highly specific for Mycobacterium TB. And so for the purposes of my talk, what I'm essentially inferring is that if you have an individual with a positive IGRA test, I'm using that to mean that they have been exposed to TB. Clearly, there are some specificity and sensitivity analyses around that result, but in general, they are thought to be highly specific tests. So this graph is taken from Public Health England's publication in 2020 and looks at data from 2019. So this is looking at individuals who have been diagnosed with tuberculosis across England. There are two graph sides to this. You'll see on the left-hand side, these are the rates and the number of TB cases in people born in the UK. And then on the right-hand side, individuals born outside of the UK. And you can immediately see, if you look at those red bars and red boxes, that the rates of TB are much higher in people who were born outside of the UK than they are in people born within the UK. And that's been the pattern in the UK now for some decades. In 2019, almost 3/4 of people with active TB in the UK were found to have been born outside of the UK. And notably, 20% of them or so developed TB within 2 years of entry. So these are the individuals who have most likely been exposed in their country of birth or their country of residence prior to moving to the UK. They've got latent TB, and then when they enter the UK, some years after that, their latent TB reactivates and they develop active TB. There, of course, may well be people who have actually acquired TB within the UK, but the majority of people are thought to sort of import their latent TB with them as they migrate into the country. And there's a lot of work that's been done on this, showing that actually moving from your country of birth or your country of origin to the UK and other low prevalence countries does seem to act as some kind of trigger. And whether that's related to the stress of moving or the eponymous vitamin D debate, which goes on and on, we're not really sure. But certainly there's an awful lot of work being done to look at individuals migrating and whether or not you could identify those people early on as having latent TB. And Dr. Parikh, one of my supervisors, his MD or his PhD was specifically about this issue about migrant screening. And we now have a very successful migrant screening process that goes on in Leicester. There are, of course, other associations with active TB. There's the social risk factors, which we've all been well acquainted with over many decades and probably centuries, sort of homelessness, substance misuse, people being incarcerated in areas with high numbers of individuals all living together. There are then individuals who have diabetes or are on other forms of immunosuppressive drugs for other medical conditions, who again might move from a latent TB state to active TB. And then HIV, which of course is the focus of my MD and is a very notable focus on a global scale, and is one of the main reasons why there was a sort of TB pandemic that was fueled. So what's so interesting about Leicester in relation to these two conditions? Well, I'm sure many of you will be very familiar with the fact that Leicester has very high rates of TB. In fact, outside of some London boroughs, we have the next highest rates. And this is data, again, I think from between 2017 to 19, the annual rate of TB in Leicester was 39.7 per 100,000. Newham was the next highest at 45, and that's far higher than many other areas of the UK. In addition, we have quite high prevalence rates for HIV. So across the UK, on average, the UK prevalence rate is 2.4 adults per 1,000 population. In Leicester, it's 4, but in fact, some areas of the city have much higher prevalence rates of greater than 10. So really, it's the perfect place to study both HIV and TB and the mixture of the two. This is a graph again from Public Health England from 2018, which actually was the latest data that I could find. They're often a little bit behind in publishing their data. And essentially this looks at the proportion of people with active TB in the UK who were co-infected or known to be co-infected with HIV. And it's strongly recommended that any individual diagnosed with active TB should be tested for HIV. There's always a few that slip through the net, but I think the rates of testing have certainly escalated. If you look at the red bar here, this is the overall percentage of cases of active TB where there was HIV co-infection. And if you look at the most right-hand section of the graph, which is the latest data, you'll see that it sits at somewhere just under 3%. I think it's 2.8%. The rates were much higher in the early 2000s, and this probably coincided with a great number of influx of individuals from sub-Saharan Africa, particularly places like Zimbabwe. And gradually that's become more controlled, and the number of cases has gone down. So it sounds really, if you look at that graph, as though there perhaps isn't a very big problem. 2.8% of the total number of people with TB across the UK doesn't sound like a great many, but of course this is data across the UK as a whole. It doesn't really go into detail about individual areas where the rates might be much higher. In terms of the evidence behind screening individuals with HIV for latent TB and offering them treatment, it's nationally and both internationally recommended to do so. So the WHO have a drive to screen for latent TB and treat, predominantly in high prevalence settings, but increasingly there are publications coming out of the WHO which are looking at low prevalence settings, which would include the UK. Even though we have areas of high burden of TB disease, overall our prevalence is considered low in comparison to other countries around the world. There's a Cochrane meta-analysis which supports treatment for latent TB in individuals with HIV, And the idea is that it reduces your risk of clinical TB by offering chemoprophylaxis. And the Cochrane meta-analysis found that it probably reduces your clinical risk by about a third. And then there are national guidelines which support screening, both from the British HIV Association and also from NICE. And there have been various iterations of these guidelines. So when I first started my MD in 2014, the latest guidelines from these two institutions was from 2011. And the latest iteration now is from, I think, about 2016. So lots to think about, really. And the MD that I pursued had 4 studies which ran concurrently. And these were the 4 areas that I looked at. So the first one was that I wanted to really try and assess what was actually happening on a national level. Because yes, there are all these guidelines, but what is that translating into? Is anybody following the guidelines? Is anyone actually screening their patients for latent TB? And if so, how are they doing it? Who are they choosing to screen? I then wanted to look in more detail about what the actual risk was of active TB in people living with HIV, bearing in mind that that national data says 2.8% of people overall in the UK who have TB are HIV infected. Actually, is the risk quite low then, or in fact is the risk still quite high, even though we live in the UK? The other aspect to look at was what the patient perspectives are regarding treatment and indeed screening for latent TB. So the first principle of introducing any screening program is that the screening itself and the subsequent treatment or management should be acceptable to the individuals for whom the screening is designed. And as far as I was aware, there wasn't any specific research looking at whether or not people living with HIV were happy to go ahead with screening for this condition. And then the 4th study was to actually go ahead and implement latent TB screening in our population in Leicester. And the idea was to put all of that information together and perform some cost effectiveness analysis with the ultimate aim of perhaps informing national guideline or national policy. So I'll go through each of these studies in turn, hopefully to try and make things a little clearer for everyone. So the first one was to assess the national current practice, and this was published in Thorax a few years ago. So essentially it was a survey of HIV centres around the UK. I broke the UK down into different geographical areas because of course different geographical areas will have different HIV centres controlling the care of patients in those areas. I emailed or telephoned out, if they didn't respond to my email, a questionnaire and hassled and cajoled people to complete it. It wasn't considered necessary to have ethics approval because it was really an evaluation of clinical practice, an evaluation of service. And the questions were quite varied, but essentially asked people whether they were screening their patients for latent TB in their HIV clinics. And from that, I was able to work out who was adhering to the UK guidelines. And if they weren't screening, why they weren't screening. And I think it's probably important to mention that, interestingly, although there were 2 guidelines asking people to screen from the British HIV Association and from NICE, actually at the time that I started this, they were quite incongruous and quite complicated. And it was understandable that if you were your average, genitourinary medicine HIV physician who wasn't particularly well versed in TB treatment or management, that you would really have some difficulty trying to understand who it was that you should be screening. So it was very interesting then to go ahead and see what was actually being translated into clinical practice. I had quite a high response rate, about which I was rather pleased. So 87% of centres responded. One of the questions that I asked them was how many patients they were caring for in their HIV centre. And from that, I was able to work out how many patients overall in the UK were being covered by these responses, because Public Health England have an idea about how many patients are infected with HIV across the UK and how many are in care. And so actually what I discovered was that the responses that I had between them covered about 90% of the UK cohort of people living with HIV. So that was actually very helpful for me because I felt that this was therefore a very sort of representative sample of people. Importantly, of course, there were people who didn't want to participate or didn't respond to my request to participate, and there were no differences in characteristics between the 2 groups, so that was encouraging. Overall, we found that just over 57% of areas offered any form of latent TB screening. So that means that just under 50% of people were not offering screening of any type. The table that I've put here is taken from the paper, and essentially what it did was to break down the geographical areas in the UK into different subsections according to what the HIV prevalence was and what the TB incidence rates were in each area. So the most top line, the top line on the table was areas where you had both HIV prevalence that was high and TB incidence that was high, ranging all the way down to areas where you had both low HIV prevalence and low TB incidence. So the Isle of Wight, for example, high HIV, high TB would be Leicester, London, those kind of areas. What I think was very interesting was that of the groups of centres that didn't offer screening, if you look at the little box that I've circled in yellow here, a quarter of those areas actually were in areas where there was high HIV prevalence and high TB incidence. So it was very interesting to me that despite living in areas where there was potentially quite a high burden of disease, these centres were still not offering screening. And overall, the reasons that were expressed by these centres for not offering screening was that they felt that their cohort was at low risk, and certainly that may have been true in some areas of the country. They had, demographics of individuals, perhaps a high proportion of gay white men, for example, born in the UK, who wouldn't necessarily be expected to have high rates of latent TB, and so it was for those reasons that they weren't offering screening. There were then other centres that said that they really felt that the guidelines were just too complex. They just couldn't see their way through them and wanted to wait for more evidence about who they should screen. And the costs of the tests were therefore implicated in that. So there is a cost. The test itself has to be taken, it has to be run in the lab, it has to be looked at, and then the result analysed and then appropriate treatment instigated. So having established that national practice was somewhat heterogeneous, really, you had about 50% of people screening, 50% of people not screening, and some concerns around that. I then went on to look in more detail at what the risks were of active TB, and I did that by looking at our cohort in Leicester. So what we know so far from previous studies is that if you give people with HIV antiretrovirals, and now everybody is recommended to be on antiretrovirals irrespective of what stage of HIV you present with, if you give them treatment, then the aim of that is to reduce the viral load within the bloodstream and subsequently increase their CD4 count. So it's a marker of their immune system. So as their virus is controlled, their immune system recovers. And you do that in order to reduce their risk of opportunistic infections with unusual pathogens. You reduce their risk of HIV-related cancers, and you ultimately increase their life expectancy to near normal. So if you've got a young man, for example, in his 20s now being diagnosed with HIV, as long as he is adherent to his treatment, I would expect him to have an entirely normal life expectancy. Apart from the slight inconvenience of having to take 1 or 2 pills a day for the rest of his life, or until we find a cure, he will otherwise have a normal life, and that's really what we're aiming for. However, previous evidence has shown that even if you give people antiretroviral therapy and you improve their immune system and you control their virus, their risk of TB doesn't return to the background risk, that there is still some increased risk just by virtue of having HIV that means that your risk overall of having TB is higher. So this is data from the Lancet from 2015, and if you look at the graph on the right hand side, you'll see here the rates of TB in people who are HIV positive, denoted by the red bars, and versus those who are HIV negative, denoted by the blue bars. And across the ethnic groups, you'll notice that the rates of TB are higher across the board in those who are HIV positive, even though they're on treatment, as opposed to those who are HIV negative. So there's something still about having HIV that means that you are at increased risk despite controlling your disease. So I went on to look at all of our patients who had ever sought HIV care in Leicester. I included everybody who was greater than 16 years old, because children under 16 are treated still by paediatricians in Leicester. We have a separate group of patients who are younger, treated by paediatric care. I went back as far as I could, as far as records would allow, and the first patient that I had was dating back to 1983, and I ended the study in the middle of 2017. So everyone who sought care for HIV in Leicester in that time frame was potentially included. And I looked at their paper records and more recently their electronic records in order to confirm their diagnosis of active TB. And we also did some cross-referencing with Public Health England data, because there are groups of patients within our HIV cohort who are quite mobile and they move around the UK quite frequently. And so if they were diagnosed with TB somewhere else in the UK, I wouldn't necessarily know about it. So we did some cross-referencing with Public Health England in order to capture people that had either moved on from Leicester since we saw them or had been cared for somewhere else prior to moving to Leicester. And what I really wanted to know was, of those people who have active TB, when does it occur in relation to their HIV diagnosis? What are the risk factors for their active TB? And as a result of that, to try and gain some understanding about who we therefore might target in order to undertake latent TB screening. So this is a little flow chart. Essentially, after we had some exclusions, we included 2,158 patients. It took quite some time, as you can imagine, to go through all their data, but I discovered that 15% of them had a history of active TB, so there were 325 cases. Of those, 20% of people were diagnosed prior to their HIV diagnosis. I should mention the caveat to this, which is that often this was self-reported. So if we had individuals who were seeking HIV care in Leicester but had been born in sub-Saharan Africa, this was often history that they gave when they first presented for care. They said, oh yes, I had TB treated a few years ago in Zimbabwe and I received treatment. Now, obviously it wasn't possible for me to verify that, so I had to go on the history that was given to me by the patients. It's quite possible that some of those patients may not have had TB. They may have had a completely unrelated diagnosis. It's equally possible that they may have in fact been HIV infected at the time but never received a test or had inaccurate testing. So I can't verify all that data completely, but it's to the best of my knowledge. 50% of people were diagnosed with TB either at or within 3 months of their HIV diagnosis. And this is quite a common scenario for us. We still see people like this. So they come in, they crash land through the door, they've never been tested for HIV, or if they have, they've never engaged in care. And they come through, they're unwell, they're febrile. We do some investigations and we find that they've got active TB and we diagnose them with HIV at the same time. So this is a high proportion of people, crash landing with HIV and TB at the same time. But this group are of particular interest. So 30% of the people who were diagnosed with active TB during their HIV sort of journey were diagnosed longer than 3 months after their HIV diagnosis. So this is the cohort of people who we would term as having what we call incident TB. And this is the group of people who could potentially be prevented from having TB. If they were screened for latent TB at the time of their HIV diagnosis, once they'd engaged in clinical care, you could potentially prevent them going on to develop active TB down the line. So this is a very important and interesting group. So we found, TB risk we felt was really quite high, despite those PHE figures that 2% or 2.8%. Actually, if you're HIV positive, your risk of having TB at some point is really high at 15%. And the incident risk, this risk of having TB once you've already been diagnosed with HIV, is 4.47 per 1,000 person years, which is much higher than the baseline rate of TB across the UK. I then went on to look at reasons why these individuals may be developing TB. And what we found was that it really comes down to your ethnicity and your country of birth. So amongst our white cohort, so within my 2,158 people, 647 of them were white, and only 21 of them, so 3.2% of white people had had TB, as opposed to 20% of Black Africans and 28% of South Asians, and that was all statistically significant. Overall, 302 people out of 325 who had had active TB were born outside of the UK, so 93%. So clearly, sort of going back to the original data about how TB is much more common in people who are born outside of the UK, this is mirrored in my data here. We then went on to specifically look at what might be their predominant risk, and what we found is that it really boils down to the TB incidence in their country of birth. And so this essentially is how likely are they to have been exposed to TB in their country of birth and be carrying latent TB with them, which then might reactivate later down the line once they've developed HIV. This is the data from my paper on this, which shows that in comparison to being born in a country where the TB incidence is less than 50 per 100,000, and that would include the UK and many other sort of Northern European countries, your risk goes much higher. It becomes much higher. If you look at the adjusted hazards ratio, the risk is much higher if you've been born in a country where the TB incidence is raised. The numbers seem to drop off a little bit when you get to the high incidence countries greater than 350 per 100,000. We think that's probably just to do to the number of cases that we had in our own cohort from those countries, rather than it being a true effect. I've underlined the line of between 150 to 249 per 100,000. As you can see, most of our cases came from countries born in those high incidence countries, and they would include many sub-Saharan African countries. So what have we done so far? We've established that national practice is rather heterogeneous. There's a bit of uncertainty as to who to screen. We have, however, discovered that the risk of active TB is still quite high if you have HIV, so it's an important problem. What we need to do now is to discover whether patients themselves are in agreement with the idea of screening for latent TB and going on to accept treatment. So, as I mentioned in my introduction, the acceptability of testing with an IGRA test and then going on to receive treatment for latent TB if you're HIV positive is largely unknown. There are cohort studies that have been published that show that individuals with HIV do seem to have good uptake, both for screening and treatment, but there hasn't been any formal acceptability studies performed before, to our knowledge. So we undertook a patient questionnaire study, which had 24 Likert scale questions and then some free text answers at the end. I recruited patients attending our HIV service in Leicester and also a secondary site in Coventry where a colleague was working. This did require ethics approval and was university sponsored. We offered 716 people the questionnaire and 62% of them completed it, which again I thought was quite impressive really. I didn't expect to have a return rate that was that high, and I think to some extent this very much highlights the engagement that I had from my colleagues who were very supportive of my research. They were very supportive of looking at this in more detail and were very encouraging and very engaging towards the patients in clinic, explaining things to them, giving them the appropriate material for them to read and ask questions. So I'm very grateful to them for their support. We asked lots of different questions, but essentially it boiled down to a couple of very key ones, which is what the individual's intent was in relation to undergoing latent TB testing and treatment. So in response to the question about whether or not they would intend to undertake latent TB screening if offered, 95.4% of people either strongly agreed or agreed with that statement. So that's very high intent. Subsequently, we asked them what their intent would be in terms of accepting treatment if they were found to have latent TB and the treatment was offered to them by their clinician. And again, there was very high response there. So 92% of people were very keen and said they would intend to have treatment if it was offered to them. So then every individual enrolled in the questionnaire study, and in fact all of the individuals who didn't respond to the questionnaire study, so if you like a sort of parallel comparison group, all of those individuals were then offered latent TB screening, which they could accept or not as they chose. And so this was to test the theory that what people intended to do on paper would actually translate into action. And what we found was that it did. So of the people who accepted the questionnaire, you can see that's the left-hand side of the table, 99.2% of them did go on to accept appropriate IGRA testing. And the reason for that is that actually there were some people enrolled in the questionnaire who then disclosed that they had actually had TB, even though there was no record of that ever having been documented in their notes. So obviously they were excluded then from going on to have testing. But of the people who had never reported TB and who were then offered testing, there was a very high uptake. Similarly, amongst the people who had declined to participate in the questionnaire study, there was also very high uptake. And I think that's very important for me to be sure that the people who answered the questionnaire weren't just a self-selected group who were just naturally more engaged and naturally more interested in having healthcare interventions. Actually, across the board, everyone was very happy to have the test. Some of them didn't want to answer any questions. And there was no difference there between the two groups. So obviously some individuals were, as a result of the screening, then diagnosed with latent TB, and their clinician went on to offer them latent TB treatment. And of those individuals, again, there was no difference between the two groups. There was very high uptake of treatment. And in terms of actually completing treatment, which I should stress is around 6 months, so not an inconsiderable length of time, there was very high completion rates overall. And again, there was no difference between the two groups. So my conclusion from this study was that latent TB screening and testing is highly acceptable amongst this population, and that although they are highly acceptable of the idea of screening and testing, that does translate into actual action, and that their rates of uptake of screening and their rates of chemoprophylaxis completion are similarly high. So the fourth study was then to go ahead and implement latent TB screening. So I'm obviously mindful of the fact that when I started the project, there were guidelines as to who to screen. They were incongruous. And so as a department, we took the line that we would just offer every single individual screening and see what came out of it. And of course, that would come with the understanding that we might discover that not everybody needed to be screened based on cost effectiveness analyses, and that therefore there was a risk that we might be over screening during this process and sort of spending more money than we necessarily needed to. But we felt overall that the data just wasn't there to guide us very clearly as to who to screen. And so everyone was in agreement that we would just offer screening to everybody and see what happened. So I had buy-in from my clinical colleagues. I also had buy-in from the lab, who were suddenly bombarded with an enormous number of quantiferon tests and were absolutely fantastic in turning these around, incredibly helpful, very engaged, and I extend my thanks to all of them, because this was a great deal of work for them. So there is little published data really on prospective programmatic latent TB screening amongst people living with HIV in low TB incidence countries. There are some small studies out there, but nothing on the scale that we proposed. So we, as said, aim to just implement wide screening and then try and work out which groups we should target from screening on an ongoing basis. So this shows the number of IGRA tests that we undertook in our HIV cohort. So as you can see, going through the early years of the 2000s, from when the IGRA tests were first available, there had been some ad hoc screening. My colleagues and I had occasionally screened people for particular reasons, but the numbers were relatively small. So we massively upscaled this, and during 2014 and 2015, we endeavoured really to undertake a screening test in everybody in our cohort who had not already been diagnosed with active or latent TB in some other setting. So it's a huge undertaking. By the time I finished the study at the end of 2017, or the middle of 2017, I'd pretty much got through all of our cohort. There were a few patients, I think 17, where I hadn't quite managed to get them into clinic and screen them, but the vast majority of people, we managed to get through them. So in total, if you include the cases of ad hoc screening that had been going on before, overall we ended up screening 1,167 patients, and 142 of them, so 12.2% of them, had a positive IGRA. And as you might expect, this sort of mirrors all the results that we'd seen before, really, which is that of our non-UK born individuals, 17% of them, 16.8% of them were IGRA positive, compared to only 2.9% of people born in the UK. And I was always very interested in those few individuals born in the UK who were white and had never really seemed to have any other risk factor. And I went back through their notes, and many of my colleagues asked them where they thought they might have picked it up. And it was interesting that actually in a number of cases there was a very clear risk. They'd been living with a relative who had TB, or they'd worked abroad, or there was some obvious risk. Only one individual was diagnosed with active TB as a result of the screening programme. So generally the sequence of events was that they would have a quantiferon test done as part of routine care when they attended for clinic. If that result was then positive, at the next clinic appointment, they were then reviewed by their clinician. They were examined, had a history taken to check that they didn't have any symptoms suggestive of active TB. They had a chest x-ray done, and if they were completely well, they were diagnosed with probable latent TB and offered chemoprophylaxis. If there was any inkling that they were in any way unwell, losing weight, fever, cough, so forth, and so forth, then they would undergo more detailed testing. And one individual was diagnosed with active TB. So he probably would have presented at some stage. It was just that the positive IGRA sort of prompted the discussion. So everybody else was diagnosed with TB. And 95% of people went on to complete treatment. In fact, that figure might even be slightly higher now, because there were a couple of people who were still on treatment. Again, similarly to the study looking at active TB risk, we found that really it all boiled down to your TB incidence in your country of birth, and that was your predominant risk. So the risk of you having latent TB and a positive IGRA test really boils down to where you were born and your risk of having acquired TB early in life. And so this, again, sort of is really very similar to the previous table, showing that in comparison to being born in a country of birth where where the TB prevalence is less than 50 per 100,000, your risk goes up the higher the higher the incidence rate in the country where you're born. Interestingly, all of the individuals who were born in a country where the incidence was between 50 and 150 per 100,000 who had latent TB, all of those people were actually born in sub-Saharan African countries, which led us on to propose what I've sort of dubbed the Leicester Model. I really think I should probably thought of a better name for it, really, but that's what I came up with. Might change it in a publication perhaps. And so our model was that anybody who's born in a country with a TB incidence of more than 150 per 100,000, plus anyone born in any other sub-Saharan African countries with a slightly lower incidence rate, that really we should concentrate on those individuals for screening. And if you do that, you would only need to screen 670 people out of the cohort that we had in order to identify 87.5% of the total IGRA positive cases. So you get really quite a high yield. Of course, you're going to miss some individuals, but from a cost effectiveness point of view, you don't have to screen everybody. Whereas some of the other guidelines that are in place would really indicate that you would need to screen everybody in order to pick up 100% of IGRA positive cases. But the question is whether or not that translates into a cost effectiveness approval, if you like, given that the costs of testing and subsequent treatment and so forth are fairly expensive. So what I was able to show through this screening was that, hard as it was to get all of these people a positive or even a negative IGRA test, it was feasible. I was able to undertake it as part of clinical care, and it was difficult, but it was a catch-up program really, in that I screened everyone who was on our books. Most people hadn't been screened before. Whereas once you've done that, you can then just concentrate on just screening the new people that come through, which makes it much more straightforward. And I also showed that the rates of chemoprophylaxis completion were very high in this group. Again, these individuals are already engaged in clinical care. They're already on antiretrovirals. Over 95% of our patients are virologically undetectable, so they're already used to taking treatment on a daily basis. And so, 3 or 4 extra pills for 6 months wasn't really a big deal once you properly explained what the rationale for treatment was. So they were the 4 studies that I did, and the idea was to feed all of that information into some evidence which could then inform national guidelines and policy. And probably the most important one of that is to do some cost effectiveness work, and that is ongoing at the present time. So Dr. Parikh and I are working with a collaborator in London to look at all the data and to do a formal cost effectiveness analysis. And there has been cost effectiveness work done in the past, but I think probably we have a greater data set than the evidence that's already out there. And then the aim is to try and hopefully inform future screening policies by really nutting down and working out exactly who you should screen in order to get the best yields. So in conclusion, we've shown that people living with HIV are at increased risk of TB despite living in the UK and despite having adequate antiretroviral therapy. And their increased risk is not just crash landing through the door as their first presentation, but actually even once they're engaged in care, there is an increased risk of TB. The guidelines that are out there do vary in their recommendations, and it would be nice to have it all streamlined so that everybody across the UK was clear about what was expected. I'm very aware of the fact that many areas of the UK have people looking after patients with HIV who are not infectious diseases clinicians. They're genitourinary medicine physicians who have other interests, which include, contraception, family planning, and STI screening. They're not people that are necessarily very well versed in TB management or TB screening. And if you want to make things straightforward, it has to be easily understood by people that are not experts in the field. I found in my screening study that screening practices in the UK are very heterogeneous. There's a lot of uncertainty as to who to screen. There might even be some disparity in care, really, with one area saying that the test is too expensive and the other willing to bear the cost. So that needs to be streamlined. I've shown that if you implement screening as part of routine clinical care, it is feasible and it's highly acceptable to patients, and they have very good completion rates. And what would be really fantastic would be to go back in a few years and rerun all the analyses on our cohort here in Leicester to see, actually what are the rates of active TB now? We've screened all these people, we've tested all these people, we've given them all chemoprophylaxis, and they've completely they've completed their treatment. Actually, do these people go on to develop TB still, or have we managed to abort that? And as I said, we're doing some further work to better understand the health economics. And my final slide is just to point out that I did this part-time over 5 years, and there are an enormous number of people to thank, predominantly my supervisors, obviously my family who put up with me while I wrote this endlessly, and all of my clinical colleagues. I would particularly mention Dr. Ian Stevenson, who's the head of our HIV department and was eternally enthusiastic and very keen to push things forward, particularly when I started this as a registrar and had very little influence over anyone or anything. Lots of other people in Public Health England and the other health protection organisations around the UK. And also, just to point out, I did get some charitable funding from the hospital for printing the questionnaire study, and then the other funding, as I mentioned. So thank you very much indeed for listening. It's been a pleasure to present my work, and I'd be very happy to take some questions. Thank you.
Okay, thanks very much, Helena, for I'm sure you'll agree a really excellent and very, very clinically relevant piece of research. It's been a real pleasure to listen to that, and I think I've listened to pretty much most of the Lauder lecture series over the years, and this is very much in keeping with that particularly high standard. So really, really nice presentation. We've got some time for questions. Would anybody like to ask anything? If you do, please unmute yourself and speak. Any questions from anybody? Otherwise, I'll just plow in. Maybe I need to ask a question just to get people go. Okay, go for it. Alex.
I've not got a question. I was just going to say, if people put up their hands, I can unmute them using the controls.
Okay. Well, maybe if I ask a question first, it'll stimulate others to have a go. So my research interest is in opiates, and we know that opiates are profoundly immunosuppressive. And I wonder if you collected any data on whether your patients were intravenous drug users. I mean, the figures in the States, what about 1 in 10 HIV patients are intravenous drug users? And I wondered if you had any data on that. Might be quite fascinated to see if there's any correlation there. And compliance is really low as well. So with screening, they're not going to comply, maybe.
No, so actually that's a really good question, and I'm ashamed to say that I didn't, and I did for a small number of people. I wish in retrospect that I had collected much more extensive data about each of the patients, and it was one of those things where sort of halfway through the study I thought, gosh, I wish there had been other parameters I'd looked at. The only group of people that I did look at that for were the unusual white-born individuals in the UK where they'd got TB, and I thought, well, this is interesting, you know, why have they got TB? And I did look at their risk factors, and actually a number of them were intravenous drug users. So which, you know, I think probably partly explains why they may have been at risk of TB. As you know, in Leicester, we've got, you know, big cohorts of people, and there've been some large outbreaks of TB amongst houses of ill repute, and certainly around pubs in certain areas of Loughborough. It would be nice to have collected that data for everyone, but certainly I did see a little bit of a theme about amongst the slightly unusual white-born individuals.
Is that interrogable in the data set that you've got hidden away somewhere in a spreadsheet anyway? I'm just curious. Probably not. No,
the only way that it would be is that when people get enrolled for HIV care, there's a national kind of database that we use, and one of the parameters that we collect is how they acquired their HIV. So there are a number of individuals in our data set, and their only known risk factor is injecting drug use. But that's not going to include people who perhaps acquired it, you know, through sexual intercourse, but also happen to be a drug user, if that makes sense.
Yeah.
So yes, so I think there could be some limited analysis on it.
Okay. Any other questions from those on the call? Don't be shy. We've got a couple of minutes if you want to ask any more questions. Any other questions from anybody? I think you've stunned them all. Most of them are your colleagues. Maybe you'll see them during the week, and you don't question the home team.
Yeah.
No more questions from anybody? Okay. In that case, you've used up two doctoral inaugural lecture times worth, so
sorry.
It's definitely been worth it, and I've thoroughly enjoyed listening to what you have to say. So to conclude, ladies and gentlemen, your doctoral inaugural lecturer, Dr. Helena White, and also the MD prize winner, and a round of applause electronically. I wish it could be in person.
No, so, it's a pleasure. Thanks for inviting me.
Thanks. Okay. Have a good evening, everybody.
Thank you.
Bye-bye.
Bye-bye.